preserved ejection fraction as cause of dyspnea. Professor Brunner.
Thank you very much, Chairman, ladies and gentlemen. I'd like to thank the organizers that I can be here. It's a great pleasure for me always to come back here to Switzerland. Well, I'm still living in Switzerland, so in that way I'm often here, but to be able to participate here, it's really a great pleasure to me. I've been given the task to actually say a little bit about preserved ejection fraction as a cause of heart failure, and I actually could make it very simple because, well, it's just what you just heard, particularly from Beat Kaufmann. What are the signs and the symptoms actually of heart failure? You do echo, and while we don't really have much treatment in HFpEF patients in heart failure with preserved ejection fraction, so I actually could stop here. But there are still some issues to be resolved, and I also would like to give you some insight why I think HFpEF is different, but also to give some insight in pathophysiology, because I really think this actually affects also the way how these patients can be managed. Oops. You've already seen this scheme from the new guidelines, and I really would like to emphasize that in the new guidelines that the algorithm about diagnosing heart failure is much clearer than it used to be. They also have put more emphasis on the use of natriuretic peptides. It doesn't really make a difference whether you use NT-proBNP or BNP, while in the chronic setting the levels actually to exclude are a little bit lower than in the acute setting. And they also have emphasis on symptoms of heart failure. There is also a very recent symptom, and I'm not sure whether you're aware of, but this is really something patients often talk about. So if they bend over, that they are short of breath, and this is actually a sign of elevated filling pressures, or can be. There is also emphasis on other symptoms such as orthopnea, paroxysmal nocturnal dyspnea, but you all know, also the pulmonologists, that many patients with COPD actually have the same symptoms. So you can't really say just based on the symptoms that you can make a proper diagnosis. Actually, this pathway is independent of ejection fraction. So this doesn't just apply to patients with HFpEF. This is really just diagnosing heart failure in general. What then actually is distinguished is, and the definition of HFpEF actually is based on the ejection fraction. You just heard that there are limitations in assessing systolic function, and there are also some indications that also in patients with preserved ejection fraction, there is also some signs of systolic dysfunction, as you just heard. But basically, the distinction between patients with reduced ejection fraction and preserved ejection fraction is based on ejection fraction. It's obvious. It's very important because in this group, it's fairly simple and straightforward. And it's also that we have many of the heart failure treatment that we actually are using improve prognosis in this group. But they don't do much, or they don't anything at all in the patients with HFpEF. I'm coming back to that a little bit later. There is also a group in between, and the new guidelines actually have created this HFrEF group, heart failure in the mid-range. It's not mildly reduced, but you could also use that. Mid-range ejection fraction. And when you look at the criteria, it's actually the same here for this one and this one. I personally have some problems with that, particularly because the range that you can see here is smaller than, well, actually the reliability of the measurement, as you just saw. So I think there will be a lot of discussion about that, how this actually will work out in clinical practice. The idea behind this is actually to stimulate research, because we don't really know much about this group. I personally think, and we'll show you also why later on, that this group actually is much closer to the HFrEF group, to the reduced ejection fraction, than to the preserved ejection fraction. When we look in clinical practice, this is rather old data, but unfortunately I must say that I don't really think that this has largely changed. That in clinical practice, often the diagnosis of heart failure is made just purely based on symptoms and signs. And you saw that there is quite a big uncertainty about that. But even more importantly, I've just shown you the important distinction based on ejection fraction, because this really has direct therapeutic impacts. And just purely based on this, even if you're sure that the patient has heart failure, you still need to know what the ejection fraction is, because otherwise you can't really properly treat the patient. And you see here that, well, often it's really said that, well, echo is supportive but not really necessary, and I really don't agree with that. So I think this is very important. So why is this question about, well, the ejection fraction? Because there are some arguments, particularly in the past, to show that it's more or less a continuum. That's a relatively old study, but there are more of them when you look at just heart failure populations, and you don't really see a clear cutoff. This actually also created this mid-range ejection fraction, but it's not really that easy to distinguish between, well, normal and reduced ejection fraction. Also, when you look at some physiological data, here measured invasively also during exercise testing by Micha Mäder, you actually could see, of course, the patients do less. They have much quicker increase in filling pressures. So left atrium pressure increases. They also have faster increase in heart rate. They have reduced stroke volume. So you don't really see a big difference when you do the same in patients with actually reduced ejection fraction. And there is a recent study actually published this year, and they looked at echo findings. You heard about them also during exercise, and they actually saw in patients with HFpEF, they all had everything excluded, that you saw a nice correlation actually with this EE prime, but also strain. So to some extent also some mild reduction of systolic function, and the editorial that is accompanied by, or that accompanies this publication actually concludes that HFpEF patients are more similar than different. And it seems likely that global reserve limitations in the heart, arteries and periphery actually is causing this process. And that we just need to define that or find that, and then we know how to treat these patients. And this is actually the pathophysiological background of that. So you have some increase in stiffness of the myocytes in the myocardium, but also of the extracellular matrix. You have some ventricular vascular uncoupling with increased vascular stiffness. You also have some peripheral problems, and you have also some chronotrophic incompetence, and this actually together causes HFpEF. The problem with this is that if we think what actually could be done here to modulate these processes, you actually would think of ACE inhibitors, of spironolactone, maybe of beta blockers. So actually the same medication as we have in patients with reduced ejection fraction. The problem is that they don't work. And this is, I'm not going to show that because it's about NT-proBNP guided therapy, but what is done in all these studies, and this is actually a meta-analysis based on individual patient data, is that in the BNP guided group, the standard heart failure therapy actually was increased. And as you can see in HFrEF patient, this resulted in improvement in prognosis, but in HFpEF patient, this was clearly not the case, maybe even a trend to the opposite, and the interaction was clearly significant. So we don't really know what we actually should be doing and how difficult it is. And this is the reason why I'm showing this slide, because very recently it was tested whether nitrates help. They don't. Here measured as well, average daily life activity measured, and actually it was even worse with nitrates. But I'm particularly showing that you see where it is published. And it's based on 110 patients in a crossover design, very short term. So that actually highlights how difficult this topic really is and how urgent there is really need to find some actually treatment, effective treatment in this patient. And the study what we have so far actually didn't show any effect. We have much based on small studies or post-hoc analysis or cohort studies, but this is still all undecided. There are also many negative studies, also with sildenafil, for instance. There was not really much effect in that. There is a really large trial, the only really large trial with ARNI, but we will see whether this comes out. But so far, and you can see that here on the left side, no effect at all. Only when you look at, well, cohort studies, but, well, then you see large effect, but this has not been confirmed. So we don't really know what we actually should be doing. And much hope was based actually on spironolactone, because as you could see, there is the thinking of that fibrosis and extracellular matrix play an important role. So therefore there was much hope on spironolactone, but unfortunately, despite, well, in this HFpEF group, relatively typical patients, 70, half of them were actually women, there was no positive effect of spironolactone. There is a lot of discussion about that, and one is whether this really was HFpEF or all patients really had HFpEF, because in those that were included in Russia and Georgia, actually the effect was negative, but also the risk was about 1/4 of those in the other countries, in the American countries that actually were included. So maybe these were not HFpEF patients, and it worked well if you really include HFpEF patients, but we will see that this is not so easy. But even more interesting analysis, I think, is this one. And when we look at that, you actually could see if heart failure or ejection fraction is really preserved, there is no effect at all. And it was really purely in the patients with mildly reduced ejection fraction, or also in this mid-range ejection fraction range where we saw a positive effect. So maybe it's really the question, if it's reduced, the medication help, but if it's not, they don't do anything at all. So the question is why, or what is really different? And there are really some characteristics of the patients. On one hand, there are much more women, much older, so it's particularly a disease of old age. It's also that comorbidities are much more prevalent in patients with HFpEF as compared to patients with HFrEF. And when you look also at hospitalizations, they also have more non-heart failure related hospitalizations. And the same is true also related to death. So this is an analysis of time CHF, and we found much more patients not dying from cardiovascular causes in patients with HFpEF as compared to HFrEF. So it seems to be that comorbidities and all that actually takes place in these patients, and as I said, it's mainly elderly patients. They have many comorbidities, and it's more and more recognized that this actually may play an important role. What you can see here in this nice review is that you both have cardiac or cardiovascular comorbidities, but also many non-cardiovascular diseases. And I think this is very important because if we look at diagnostics, of course you see also immediately the challenge in these patients. Because it's not just about heart failure, it's really about, well, the problem of this individual patient. So, for instance, an important part is, for instance, chronotropic incompetence and atrial fibrillation. So if you could give a beta blocker to a patient that has a heart rate of 150, it may help. But if the same, or if a patient with a heart rate of 50 that doesn't increase during exercise also gets a beta blocker, you don't really do much good with that. If you combine these patients as HFpEF patients in the study, the result will be negative. So I think that's part of the problem in these patients. In addition, patients with heart failure, this is actually own data, and it's not just in HFpEF, but also in HFrEF, but even more in HFpEF. But if patients have additional diseases, they also have more symptoms. So these two groups were similar regarding heart failure, but they had more dyspnea and less quality of life if they had COPD. And there is also a very recent study that actually showed, after excluding all patients with pulmonary diseases, that you find in HFpEF patients actually a lower diffusion capacity. So maybe you certainly heard of the cardiorenal syndrome, but maybe we should also discuss more about, well, other links with comorbidities, for instance, also a cardiopulmonary syndrome or whatever. I think this plays an important role in these patients. We don't really understand yet how we should be treating these patients or what we actually should be doing, but I think we should look more at comorbidities. Importantly, comorbidities are not just bystanders increasing the symptoms or the problems of the patients. And I don't want to go into all these details, but if you're interested in that, this is a really nice review. And it actually gives examples of many comorbidities that are important in patients with heart failure, not just HFpEF, but also HFrEF, and also give information about how actually the diseases could be linked. One very important aspect of that is inflammation, and one theory is that inflammation actually is the common trigger for patients developing HFpEF, and also that actually would give the opportunity of treatment. However, there are two things. One is that's not yet been tested, so we don't know yet. And obviously, and this is shown here, there are diseases and comorbidities or circumstances where inflammation actually is increased, but there are also many others where it's not the case. So we don't really know that whether it's really pure inflammation, though we find in patients with HFpEF here, based on different biomarkers, increase actually in signs of inflammation here with inflammatory markers, but whether this is really a cause or just a bystander, we don't really know yet. So the pathophysiology of HFpEF actually can be summarized in a way like this one, and this is just cardiovascular, that we have diastolic dysfunction, we heard that, but we also have to some extent systolic dysfunction. We also have vascular problems, including endothelial dysfunction. There is quite a fair bit of evidence that this is an important role. We have some autonomic imbalance. We have chronotropic incompetence that is important. We have some right ventricle dysfunction. I didn't go into too many details, but many of these patients also have mild forms of pulmonary hypertension. We have peripheral limitations. So we have really a mixed bag of these patients. And what we're doing right now is we have an outpatient clinic specifically for these kind of patients, and we do detailed analysis on cardiac, but also on non-cardiac comorbidities. We do echo, we do stress testing, Holter ECG, broad testing, also not just looking at cardiac problems, but also, for instance, iron deficiency, liver problems, renal problems. We all do lung function testing, but also sleep testing. We do screening for endothelial dysfunction and COPD. If we don't know really what's the problem, we also do ergospirometry, sometimes even right heart catheter during exercise, and based on the findings we do further analysis, and we then specifically treat the pathology of this patient. And initial findings, we started with that about a year ago, but we really had not all patients, but some patients that did significantly better when we actually treated these different comorbidities. So I really think it's worthwhile in the clinical practice to do that. And lastly, what is recommended, and I think it's very promising, even though if you look at that, this is from a recent meta-analysis, a lot of screening, but just 6 studies included. But I think with exercise testing, and it's also our own, not testing, training, our own experience, that at least you can improve quality of life in these patients and the exercise performance. So that's something we do as well. So to summarize, I think it's still little understood, and I personally don't really agree that we can say it's one disease. I personally don't know, maybe it is, maybe it's not, but I think we should think broader for this disease because we really don't understand it yet. What we do know is that comorbidities play an important role, and proper diagnosis, not just based on cardiac problems, actually is really needed. You saw also in the presentation by Beat Kaufmann that many of maybe rarer or not so rare diseases actually can cause HFpEF. For instance, amyloidosis is an example. Whether you call that HFpEF is a different question, but that actually could be an underlying problem. There is no specific treatment. We use diuretics to treat fluid overload, exercise training, and we treat the comorbidities, and I think this really may result in positive effects for the patients. Thank you for your attention.